Hi, my name is Brian Dahm, I'm a fifth year orthopedic resident at Duke University. I'd like to thank the Seattle Science Foundation for allowing me to come out here and present our abstract. So the title of the abstract is Fusion Rates with XLIF. Does XLIF with BMP result in early fusion? So transosseous interbody fusion, as we've been talking about throughout the course today, is an MIS surgical technique with kind of three main goals: to achieve an osseous fusion, restore disc height, leading to an indirect decompression, and then improve sagittal balance. To achieve a fusion or arthrodesis, there's kind of four principles that you want to consider: the site preparation, having a stable construct, graft selection, and then the patient's metabolic status or protoplasm. With a lateral approach surgery, that big cage, it's a stable cage. It's in the anterior column of the spine with on the compressive side of the spine, which allows an arthrodesis or a fusion, compared to your more classic posterior lateral fusion, which is under tension. And then with that lateral cage, it's a large cage, a large surface area for fusion, and a large volume cage, which allows for more graft material to be placed. All these kind of leading to an increased fusion rate. So this is just one study that was published in Spine in 2015, looking at the fusion rates of both interbody fusions and posterior lateral fusions with BMP, and you can see fusion rates for the interbodies were all greater than 90%, and fusion rates for the posterior lateral spine were about 85%. Now, when you look at all kind of some of the studies that are currently published, the one-year fusion rates for XLIF range between 80 and 100%. Now, these studies are pretty heterogeneous with different cages, different cage materials, different graft choices. The size of the cages vary, and then the levels fused carry. And that heterogeneity is kind of what wanted us to retrospectively look at our own patients and see what the fusion rates were for our patients. So that was the purpose of this study, to assess fusion rates at 6 months and 1 year following XLIF with BMP. Secondarily, we wanted to compare pseudoarthrosis rates at 1 year and kind of assess some of the risk factors that led to these non-fusions. So the design of our study was a retrospective review over a 2-year time period, all from a single surgeon. The inclusion criteria were XLIF PEAK cages. They were the nuvasive cage. All the patients, the graft in all these patients was BMP infused. They were all supplemented with posterior instrumentation, and they all had CT scans at 6 months and 1 year. Our criteria for a fusion was bridging trabecular bone between the inferior and superior end plates, and we wanted to see that either on the sagittal or coronal view, and have at least 50% of the fusion mass have bridging bone. The levels for our patients were similar to kind of the overall incidence of levels selected for lateral fusion. Our most common was 4-5, then 3-4, 2-3, and 1-2. So we had 312 levels in 166 patients, and our overall results, our 6-month fusion rate was 51%, and our 1-year fusion rate was 85%. And this is a sagittal view here on the right, and you can see the bridging trabecular bone between those end plates. So when we looked at all of our different levels, we had similar fusion rates both at 6 months and 1 year at all the levels irrespectively between 1 and 5. The length of the construct was not statistically associated with increased pseudoarthrosis rates, and neither were patient variables. We looked at diabetes, osteoporosis, age, BMI. None of these patient factors individually kind of reached statistical significance for an increased pseudo rate. So looking at our levels, both our 1 and 2 level fusions, the fusion rates were very similar. When you got to be more than 2 levels with 3 or greater levels fused, there was a trend towards a decreased fusion rate at 69%. However, the statistics did not reach significance for this. So in summary, XLIF utilizing BMP reliably achieves fusion. The 1-year fusion rates are 85%, and half of the patients are fused by 6 months. The 1 and 2 level fusion rates are similar, with very highly reliable fusion. When it's greater than 2 levels, there is potentially a trend towards a decreased fusion rate. And patient factors did not seem to greatly influence the fusion rates at 1 year. I'd like to once again thank the Seattle Science Foundation for giving me the opportunity to come out here and talk. Thank you.